Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Drs. Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz podcast will surely satisfy your podcast fix. All right, now let's dive into this episode.
Welcome back, everybody. It's Dr. Fuller along with Dr. Butz on the Fuller Butz podcast. How are you doing, Dan?
I'm good. It's been a good day. How have you been?
I am doing excellent. It is middle of summer. We're winding down on our amazing first podcast season. How are your thoughts as you're reflecting back on the first 12, 13 episodes?
It's been good, and we covered a lot of big topics. I'm looking forward to future seasons, maybe getting in, a little bit deeper into some things and getting more guests on. I think would be great, especially talking more about facial procedures and things that the two of us don't do as much. Maybe even exploring more, reconstructive options out there. I mean, plastic surgery is such a big field. We're really just scratching the surface with, at least what we've talked about so far. What are your thoughts?
Yeah, I think some of our secret guests that we've been talking about would be excellent just to hear different perspectives. And we really need some celebrities to do some crazy plastic surgery so we can talk about it. We're just waiting for that next controversial event to happen that we can jump on. But I agree. I think pushing the envelope into deeper, more discussion, and then just opening it up to other experts. And I think we've only scratched the surface of plastic surgery. Truly, there's so much to make of it. Even this week, I feel like I've operated on like 7-8 different body parts today alone. With
an 8 body parts?
Ear reconstruction, nasal reconstruction, skin graft, distal radius, common perineal nerve release, back, 3 neck, skin cancers. It was just anatomy all over the place, and that's what makes it fun. Yeah,
it's incredible. A lot of different incisions, isn't it?
Yeah. So, today's topic is entitled Incisions, Revisions, and Second Opinions. And so what Dan and I thought we would discuss is some of the frequently asked questions that we get in the office and in consultations. And I think a lot of it just stems from mommy pages and these Facebooks for mom blogs where they're saying, oh, ask your surgeon this, ask your surgeon that, which is great. It's really important to be informed. But I think some of these heavy hitting questions we can try to knock out in our podcast to at least just provide some baseline of education for commonly asked questions that are regarding our incisions, our revisions, our revision policies, and then, how we approach second opinions.
Yeah, I think it's an important topic. One we often probably overlook a little bit, especially like breast augmentation. I don't know about you, but I tend to prefer the incision in the fold. I think it tends to hide really nicely, but to get it in the fold is really important. I see a lot of patients coming in for revisions, for second opinions from other surgeons where maybe they've bottomed out and the scar is too high, or maybe the scar was just placed too high and the breast is actually in an okay spot, but they didn't plan that appropriately. So how do you go about kind of planning your breast incision?
Yeah, for breast augmentation with lift, it starts with the physical exam, just examining what their anatomy are, really trying to point out that funny quote that we used at the first or second podcast as far as the breasts being sisters, not twins, and that there's always going to be some differences. And so trying to determine whether the folds are actually at the same level or not, where the nipple is in relation to the folds, and whether there is ptosis or droop or drag of the nipple below where it should be, the actual breast tissue that's there. For these revision cases that you mentioned, is the implant above or below the muscle, I think is very important as far as the longevity of it, and it's bottoming out on why that's happening, and really understanding the why behind it. When we're talking about routine primary breast augmentations, to me it's almost like a math game. We're doing the measurements, we're looking at the base width, we're determining the projection. I'm helping the patient select the correct and optimal breast size for them. And then there's also, just the diameter and measurement of the implant itself. And we can use that in a formula to try to determine where that fold is going to be in relation to the current fold and in relation to where the nipple would sit afterwards.
Yeah. So some of the common measurements we make, obviously the sternum to the nipple to the fold. And we like to I think we do it very similar, put that on tension and see what that stretch is like. Because when you put the implant in, that's going to be stretched out. And sometimes people have a very short fold, or it's almost a constricted or tight crease, and we need to lower it, sometimes 1-2 centimeters to get enough skin to cover that lower portion of the implant. So frequently we're lowering that, recreating the fold, which is a little bit more complicated, but really important to make sure that scar ends up in the right spot.
Yeah, I'm always measuring, both in the office and on the day of surgery. I'm measuring, remeasuring, putting it on tension, looking at the implant box, looking at what the dimensions are as far as the base width, the diameter, because oftentimes, I'll end up covering the nipple with a tegaderm, something that's a sterile prep, just because theoretically, if there's breast ducts, and at the nipple level, it could potentially threaten the sterile field. And so I put that on, but then at the end, I'm like, I really want to make sure that that's good. And so that's something that I'm doing beforehand. Do you cover the nipples during your breast augmentations?
Yeah, every time. That's part of kind of the no touch technique, is making sure there's no potential for the, duct contamination. I use a clear tegaderm. I know you do a lot of intra-op videos, but that way I can still see the nipple and, check those measurements after it's prepped. But yeah, multiple measurements and double checking is really essential to get that in just the right spot.
And so I think just quickly, just along with the common question that I get when we're talking about breast augmentation consultation in the office is, where do you place your incision? I would just say, Dan, why do we both choose, I guess, just answer for us, the inframammary fold traditionally, and then also, what's your preferred position of the implant, as long as we're going into those, questions are pretty similarly asked.
Yeah. So, the inframammary fold incision kind of in the breast crease below generally, has been shown to have a lower risk of nerve sensation issues, lower risk of capsular contraction, because you're not going through the nipple ducts or any of the breast tissue. You're avoiding, the armpit incision was trendy for a while, but you're going through all these sweat glands. You get better visualization, so you can often get better placement, lower risk of hematoma. So just a lot of benefits in that sense. I think you have more control of that pocket. And so that's why I like that. And then I see a lot, again, revisions where patients come in with incisions around the nipple and they've stretched poorly. Occasionally they heal perfect, but I think, more likely than not, they don't tend to heal as favorably as surgeons would like. And that fold incision, again, if it's placed just right, there's very little tension on it. You can almost, not even see it after 6 months.
Yeah, we talked about a case that I had recently, but a patient who had a really great result from a periareolar or an incision around the nipple 17, 18 years ago, was due for their exchange, wanted to have slightly larger implants, and ended up using the inframammary fold rather than the old incision, just based on that theoretical contamination, sterile, issues with the ducts and whether we're going in there, are we going to disrupt or distort the nipple with a second pass there? To me, it just wasn't worth it. It was a very straightforward exchange. Patient had no pain, has been asking me if they can work out, from day 2, and been kind of just going a little bit slower than I would like, but it's something that's just, it's sitting right in that fold. It's just going to fade away and disappear. So even in that case, when there's a previous scar, I'm still inching towards that IAMF or inframammary fold incision because of the great results that we can get and how hidden it can be.
Yeah. I think it's, so common, those revision breast surgeries, like patients are like, this was so much easier. I want to get back to, I was like, you still want things to heal and not, stretch, especially for tightening the capsule or opening the capsule. We want to let that set up before you start pushing on it too much.
And so a couple of questions along with your incision, Dan, just to hit home with. So breast augmentation, breast lift, your incisions are under the breast in the fold, or sometimes a small lollipop or upside down T incision. Do you use drains? Do you use stitches that need to be removed? These are common questions that I get asked.
Yeah, never drains unless there's a capsulectomy revision situation. Occasionally with lifts, I use some very small sutures on the surface, but maybe just 2 or 3 little ones I take out at 3 weeks. Everything else is dissolvable. What about yourself?
When can I shower after this surgery?
I'd say 24 hours. I'm fine with showering. There's waterproof tape on there. Normally, it's pretty durable. For your breast augmentation, patients don't often ask this, and they often can't see the scar in a lot of the photos I show them. How long do you typically make your incision?
Yeah, I try to make the incision as small as possible, but as long as I need to make it in order to, have adequate visibility. And some of that's dependent on the current breast size and the goal implant size that we're placing. So part of it is I'll actually look at the Keller funnel, and based on the recommendation of where you trim this sterile funnel is what we use for this no-touch technique to place the implant through the small incision. I have a very odd viral video that's got actually 150 million views now of me just squeezing this implant in the funnel. But it kind of gives you a guideline of how narrow you should make it based on the implant size. If you're trying to squeeze a large implant into a very small incision, there's some theoretical risk of breakage or damage to the capsule. And so I try to, provide a smooth entry point. With that in mind, and try not to beat around the bush, to me, it's typically about 4 centimeters is where I'll make it. And that's just enough for my lighted retractor to fit, for me to be able to see everything, to have suction kind of removing some of the fluid, some of the smoke from the cautery that I'm doing. I try to measure at the midline of the breast where that meridian is, and I usually go 2 centimeters back and forth, and then I may extend it, half a centimeter, 5 millimeters each way if I need to get more access, or if I'm having trouble getting the size or the implant in. Yeah,
with the bigger silicone implants, you need a bigger incision to get them in. So I've done some 3 centimeter incisions for really tiny implants, and it's a struggle to really see everything adequately. So my average is probably more 3.5 to 4. When you get up to 4 or 450, is probably getting up to 4.5, just to again not stress that implant too much. But sometimes I see certain patients come in for revisions and they have 5.5, 6 centimeter long breast aug incisions. It just that seems excessive, in my opinion. Trying to again, we want to use as small scars as possible to see adequately and get the best result we can.
Yeah, I think it's just a lot more work. Like, you don't need to have it that long. You can see everything very well, and then you just worry about disrupting the important infrastructure that's below there, the parenchyma, the inframammary fold, and all those stitches. Like, how many stitches that they put in to close that below there? Is that causing more bottoming out? And so I think it all heals well, but certainly you want to minimize that just to allow for healing and avoid any potential issues with it dehiscing or opening or having thickened scars or weakening the breast pocket itself.
So yeah, that's some good overview about breast incisions. I mean, we could spend all day probably talking about different things with lifts and whatnot, but another common one is tummy tucks. I see a lot of patients coming in for revisions. Too many of the scar is just too high. And that really disrupts and kind of elongates the mons area, the pubic area, which is not optimal at all. So how do you go about planning that scar placement?
Yeah, there was, some of our surgeons that we worked with actually had a study talking about the angle of where the incision should be. I think they determined it to be like 55 degrees or something like that from the transverse line to the vertical line. Dr. Zachary and I think Dr. Seitz had a paper on that. But mine, again, just like the breast augmentation incisions, there's math. There's a lot of calculations to it. You want to, as a carpenter does, measure twice, cut once. And so to me, it's 6 centimeters above the vaginal cleft. It's somewhere in the hairline that's there. That's, to me, is a good estimation that I'm in the right spot, because typically if you're wearing your bathing suit, you're not showing off that hair that's there. And so if you're way above that, then I feel like it's going to be too high, and that would be a red flag. So to me, it starts about 6 centimeters above the vaginal cleft at the midline, and then it's about 7 centimeters in each direction parallel before we start inching up. And I try to really see, even if they have their underwear or swimsuit on, something that can help me determine where their waistline is, where it wants to be. And, to me, it's a little bit of Goldilocks, where you don't want it too low where it's visible along their thigh. You don't want it too high where it's reaching above their love handles or their iliac crest. But you just want to, make that incision as long as it needs to be to reduce the bulk laterally, but also not, go over the top where you have all these scars that are unnecessary. What's your incision discussion with patients?
Yeah, it's very similar. I think, again, 6 centimeters come. I think the key thing though is like tension. Like if you mark that 6 centimeter when it's loose, then it's going to likely be too high. And I often will show patients, like patients often have that little fold or kind of hang. Like if you put the scar, right in where that crease is, which might seem easy, and you pull it up, all of a sudden it's like 2 centimeters from the belly button. So I mark it on a pretty extreme tension. So you want to lift that mons area up, and then mark my 6 so that that's not only pulling down, but you are lifting up a little bit. Same thing with the anterior thighs. So you have to take in all those vectors into consideration. And I'd rather have a little T incision from not getting all the skin up to the belly button and keep it low than cheat it up higher and have a more potentially visible scar, because it's much harder to fix. And then extending it out, just a natural taper. And I'd rather have a little longer scar that's easy to conceal than it being short and kind of bunched up anywhere.
And so just another common question I get is, I have C-section scars. What do you do with those?
Yeah, so we always excise those, and patients are always like, it's so low. How are you going to get that limit? So we're always below a C-section scar. I've never seen one lower than I would go. So we just get rid of all that scar tissue, start fresh. Sometimes patients have pain in the C-section scars. We get rid of that entrapped nerve, whatever the problem is. It's pretty incredible how that can often resolve a lot of that. If there's divots or unevenness related to it, we can fix that quite nicely as well. So it kind of just starts fresh.
Yeah, that C-section incision, there's just always a lot of adhesions. It's usually stuck to the abdominal wall, and patients are complaining of this overhang, this skin and fat that's drooping down. Even if they're very healthy and they have a normal BMI, it's really hard to, when you've lost the elasticity of that tissue, you have that adhesion where that scar of the skin is stuck down to the abdominal wall. And by releasing that, removing that, you can just recreate the natural contours of the body. It's really a wonderful opportunity to get that body back that the kids trashed along the way.
Yeah, for sure. And then the belly button. That's the most visible part of the tummy tuck, and I think the most important one to really get right. We want the scar low. There's going to be tension on that scar. We try to keep the tension off of bending over, but that, in a bikini, the belly button is really important. Are there any kind of strategies you use to try to optimize that?
Yeah, I've really tried to up my game with the belly button. It's the end of the case. Sometimes it's a very long case, and that's really when you got to dig in and say, hey, it's worth it to spend the last 25, 30 minutes really honing down the belly button and getting it to look as if nothing happened. And so, there are defatting techniques that you can do on the abdominal wall itself to kind of create this trough that's natural indentation where the belly button is. You can secure the belly button and make it lower, closer to the abdominal wall, so that there's more of an innie that's taken place. I've adjusted a lot of my suturing to all be internal, to be underneath the skin, so that there's not any risk of having the baseball stitch or the markings that are there. I don't use a clean circle. I make an upside down U incision so that there's more of a natural dip that's there. It's still connected. And to me, I'm still, trying to make that look very natural. And I know that's a goal for my patients as well.
Yeah, you kind of nailed it. I think, defatting, I think it's really important. We want contours. We don't want everything perfectly flat. We want it to cone in a little bit. And trying to keep that scar internal. So if it the belly button comes up too easily, I'm like, well, I need to shorten this. That's what I do. I shorten it, try to get that to pull inside so that you get that scar in the shadow of the belly button, not on the surface of it. Really big. So if I think it's too long, I will put tacking sutures to bring it shorter to the abdominal wall. Or if like so some patients who've lost a lot of weight, it's been stretched out, I'll literally remove a portion of it. So it's literally shorter as well. So kind of different, depending on the anatomy, kind of depends on how I'll manage that, but really trying to optimize that, make it as good as possible. And I love the U, the inverted U and the little V at the bottom. Sometimes I see these triangle belly buttons. I'm like, belly buttons aren't triangle shaped. The oval one isn't all bad, but they're a little bit more prone to contracting. So I like having a little kind of break up in that circle at the bottom.
Yeah, I think just for the listeners, it's not so much like you should be choosing a technique as you should just be choosing a surgeon. If they are comfortable with their technique, you see their before and afters on their website, on Instagram, and they deliver a very nice result, then feel good about it. You shouldn't be asking a surgeon to use a technique that they're not comfortable with. I had a patient who, I was getting set up to do a rectus diastasis repair, tummy tuck, and she wanted me to use a different stitch that I normally use. And I'm like, I feel very comfortable with this stitch. You may have found something online that shows that this one is better another surgeon uses, but I have my own reasons for that. So I think it's just, trusting in the surgeon, looking at their work, talking to their patients, reading the reviews, all of that information is being as educated as you can before you're making that leap of faith decision to undergo surgery.
Yeah, absolutely. Trying to tell the surgeon to change their technique right before surgery isn't probably advisable.
So we just spent a long time talking about how much time and effort we spend on incisions, and now we're going to talk about some revisions. And I would say just briefly, just because it's a common question that we get in consultations, and it's just as the patient's kind of scrolling on their phone, looking at their questions, looking at their notepad, they always ask, what's your revision policy? So, Dr. Butz, you just did a breast aug and tummy tuck, on a patient, or you're setting them up. What do you tell them what is a revision policy, and what is your revision policy?
Yeah, so we want to look at things objectively. I mean, I always say nothing's ever perfect, right? Sisters, not twins. There's going to be scars. We want to get them as good as possible, but having realistic expectations going in, I think, is really important. But, if something isn't up to my standards, up to their standards, we discuss kind of how we can fix it. If there is a little bulge on one side, I always try to chase out dog ears to make sure it's smooth. But let's say there's a little something there. It's pretty easy to fix in the office. We do that for no charge. If there's something wrong with the scar that we can fix in the office, we do that for no charge. But I like to wait at least 6 months. Let most of the scarring kind of maturate. And if it's a scar issue, I like to wait a year because scars really heal for 1 to 2 years, but give it some time, maybe do steroid injections. If it's a bigger issue, we need to go to the OR and require anesthesia. I typically waive my surgical fee, and they have to, responsible for the anesthesia and facility fees, which normally it's relatively much shorter than the original surgery, and it's pretty reasonable. But we want to be able to do this surgery safely and not try to cut corners to save costs. So I think that's an important thing, and to realize that there are risks involved and that there is some financial component to it. Breast augmentation is a little, we can maybe talk about that in a second here, but any differences for you, or is it similar?
The revision policy is exactly the same. Like, I really don't have too much to add whatsoever. I think it's 100% of what you said. I think it makes a lot of sense. And when I say that to patients, I don't really have any disagreements. They say, wow, yeah, that makes a lot of sense. I totally would not expect you to pay for anesthesia fees if I were going to be doing something else that needs to be revised or touched up. And it is not a common thing, but it's something that should be discussed, and it's important to have that. Another thing, my policies, is usually within the first year, just because you don't want somebody coming back like 7 years later and saying, hey, like, I want this fixed, you have this revision policy, we're going to do it for free. So I try to put a timestamp on it. But what I tell patients is that, if it's summer, like it is right now, coming up on 4th of July, and they want something done, but I'm not going to make them do it now in the middle of summer. They want to get it done in the winter or something like that. it's not like they're losing out on that opportunity to do that. And I always tell them that, they're kind of like my billboards. They're my, my strongest marketing team, and I want happy patients. And so the goal is, I take pride in my work. I want things and the results to be outstanding. And if there's something that's objective that I see, that they see, that's not unrealistic, then I want to do everything I can to make it right within these policies that we have as board certified plastic surgeons. Yeah,
100%. I just say we need to have identified and discussed it within a year. If you show up 2 years later, you've lost 30, 60 pounds, that's a very different situation. I'm happy to help you. I want to make it things better. And I often will discount, little things like that. If you're a return patient, try to make it more reasonable for you. But, that's kind of more related to time and weight fluctuations than anything that happened in the surgery. So, Dr. Fuller, I just had my breast augmentation 6 months ago and they're just not big enough. What can we do?
Yeah.
That's probably, boob greed is probably one of the most common things I tell every patient before surgery to expect it, because once you've lived in them for 3 or 6 months, wanting to be a little bit bigger, whatever that might mean, is very common. So how do you go about addressing that? And,
to me, it's expectations. And so, I tell patients before surgery that 1 out of 3 women nationally, when surveyed, if they had to do it over again, would choose a larger implant. So I just sort of plant that seed that there may be some underlying, I guess, boob greed is a good term in slang. It's probably something I'm going to start using now in the office to have. I tell them that I'm not pushing them to a larger implant because of that, but it's just something that we should discuss and be aware of. I always have at least 2 appointments with patients prior to breast augmentations, prior to implant decision making. And once we make that decision, which is based in part based on the geometry, the mathematical equations that we talked about at the start of this podcast, that's the decision that we made. And if somebody's not happy with it 4 months, 6 months, I'm typically saying, like, let's pump the brakes. Let's, calm down. Let's give it a full year to really, live with this. And if it's something that they're still not happy with, want a different size, despite having, the preoperative appointments, the decision capacity, the decision that we made together, that I would be happy to revise that, but they would be paying for the new implants. Otherwise, if you think about it just as a business model, it's a pretty poor model. If 1 out of 3 people want a different sized breast every single year, there's no way that we can afford to start paying for implants when people want things up, down, all over the place.
Yeah. And I think, on top of that, like, there's risk, every time you go back in, there's another risk of capsular contraction. So I similarly kind of say, I think it's worth, this is a big investment, living in a little bit, like, give it some time. The exchange is relatively straightforward and relatively, low risk, but we want to make sure where you don't rush into it. But same thing, implant fees, all of that. You want to make sure you're not rushing. And, like, I had a patient recently who lost 30 pounds and, initially just wanted a little bit of a boost. Now she's like, no, I've had them. I really want them to kind of look enhanced. So we're talking about, going up 250 cc's, up to almost 500 from 250, which is a very different kind of goal, which wasn't kind of conveyed early on. She's totally reasonable about it. I tried to get her to, be a little bit more patient, and it's just a very different goal than what she used to have. So it's worth doing it. But honestly, I think I've only upsized this might be my second patient. So we normally get pretty close to that right size, but saying you wish you had gone a little bit bigger is quite common. But most patients are close enough to their goal that it's not worth another surgery.
Yeah, 100%. That's exactly my situation. It's extremely uncommon that happens.
More talked about than actually done.
Yeah, but I think it's important to discuss that. And I think that's a good segue to the last portion of this episode, which is second opinions. And so, I had a patient not too long ago who came in, was unhappy with actually her implants, thought that they were too small, wanted them to be upsized. And despite them being done elsewhere, her result was very good, was very appropriate. And while she wanted larger implants, she wanted some other things, done as well. I, basically talked to her about, right now you're in a good spot. You went through a successful surgery. The implants are soft. You're a couple of years out to go back in and potentially risk a capsular contracture, to risk a, recovery that may not be as good, to have a size that, may not be, appropriate for you. You have to weigh on that. And so I'm not always kind of jumping in, trying to do as much surgery as I can. It's really just understanding what's driving the patient and making sure that they understand the pros and cons to any additional, steps in their plastic surgery journey.
Yeah, absolutely. I see a lot of second opinions. Sometimes it's a year out, sometimes it's 5 years out, which are going to vary different situations. But I think I always try to put myself in their surgeon's shoes. Like, it's really easy to be a Monday morning quarterback and kind of nitpick things. And I try to nitpick my own results as well, but not say like, oh, they really, you're botched. I don't really like that terminology. Like, I think it's, I don't, if you went to a good, well-respected board certified surgeon, you likely picked them for a reason. I don't think they probably did anything, intentionally to, get you botched. But, sometimes, again, we've talked about this before. A lot of the result is the recovery. Like, you only have so much control during surgery. Sometimes things do happen. I'm sure the surgeon, isn't happy with that either. But I try to talk about, just say, sometimes surgery doesn't go as planned. We can definitely make improvements on this, and then go through those different steps of how we could ideally get them to the goal they want. Because it's really easy, I think, to try to bash your competition and whatnot. But I think we're a small community. We always want to be respectful towards each other. Now, if you went to the pediatrician or the OBGYN who's doing liposuction, I might not be as normally I kind of just keep my mouth shut. But you want to do your research and find a good surgeon, try to minimize those early complications and need for revisions to begin with.
Yeah, it's community over competition. I don't think a patient is going to, be enamored with my approach if I'm talking trash and speaking negatively. That's not my job. They want a second opinion. We have to deal with what's in front of us and look at things objectively and figure out if it's something that's reasonable with the risks and benefits of the procedure to undergo a revision, if it's something that shouldn't be undergone. And so as part of that, certainly there's some red flags if somebody's coming in speaking very negatively about somebody, that this is somebody who could potentially do that to me as well. And something that I consider. But with all that aside, as far as the revisions, I think that there is an added complexity just because it's not a naive tissue that's been operated on before. There's incisions, and you're not the one who's done it. And so I think it's very important to obtain, if possible, the old records. I'm very thankful when the patients have kept their implant cards, so I can see, what the implant was, whether it was saline or gel, and what the size was, because we both have had stories in the past where they, could have sworn it was one size and it wasn't. And so it gives me more data, more information. Is not a deal breaker if you don't have that, but I'm trying to collect that to understand, and even their post-op notes to see if there was some delay in healing, something else that caused the scar to widen to something not to look as good as it can. It's very helpful to me. I even look at the stitches that were used to say, hey, you had a bunch of irritation, you had some dehiscence or opening of the incisions, let's try a different stitch to try to see if your body didn't react well to that. Do you have any other specific approaches, thoughts on the revisions that are coming into your office as far as like collecting data, doing sleuthing and investigation discovery sort of stuff?
Yeah, all that information is so helpful. Just last week I had a patient who swore she had 275s, and I got in there and there were 375s. And so we were planning on going up 100 cc's, and all of a sudden I had, fortunately have full inventory essentially. So I was able to, pivot, but, having more information just makes you more prepared. One thing I often will ask for, do you have any photos of you before your surgery? And then early on afterwards, frequently they don't have like good standardized photos, but being able to kind of get a sense for where things actually started can help you kind of see what that change was and what some of the limitations or kind of things that may have prevented that original surgeon from getting to where they wanted to be. Breast lifts, reductions are sometimes a little tricky because you don't know how they did it and where the blood supply might be coming from. So you have to be a little bit more careful with that. But I've been seeing a lot of those revisions lately.
Yeah, I think if I'm trying to, put tiers on the level of difficulty, doing a revision to a augpexy or a lift with an implant to me is very challenging, just because there's so many moving parts. Oftentimes, they don't like the implant size that they have, and so if you're changing the pocket, if you're changing the plane of the implant, and then the blood supply is a real guessing game oftentimes if you don't have the operative report. So you're really having that discussion with the patient, discussing what the potentials are after surgery, and then just weighing the pros and cons if this is the right time to intervene, and what the possible outlook would be for results. Oftentimes they end up getting to the finish line well, and they're happy, and those can be great cases. That can turn into, I think, good business as far as like for our med spas for tucks and lasers and peels, and somebody who just you gain confidence for, they can become a lifelong patient. And I've had certainly like a patient who had an issue with their tummy tuck by another surgeon that I revised, and then I did her thigh lift, and so it's just kind of like an entry point into a new relationship with a patient and a doctor, where we can continue to offer services for, which is a great thing. It's not just cleaning up something, but providing new ways and then new circles of happy patients talking about us.
Yeah, I think again, oftentimes people think surgery is like, sometimes I feel I'm sad when this happens. When patients come from far away, I do a breast aug, and I've had patients I've never seen afterwards. I'm like, I really want to see that result. And we've had virtual touchbacks, and they're like, oh yeah, everything's great. They're awesome. I love it. But, being able to get the photos, examine it, see it, talk about, how happy, a little bit more extensive, how happy they are. And kind of going back to you, like every one of our patients is, basically, an influencer, micro influencer for us with their community. We want them to be happy. We want them to be talking to their friends about it. Because these surgeries, I just recently had a patient go in, she's like, I can't believe I waited so long to do this. Like, this is so awesome. I thought this was kind of silly, but like, I'm just in love with how clothes fit now, bikinis, all this stuff. And like, it's like, this is great. Everyone should do this if they want to. So I feel like there's a lot of these little roadblocks that patients set up for themselves, that it's, for vanity, or they don't want anyone to know, or this or that. And if you talk to someone who's had a good experience, happy, it kind of can help break down some of those and really allow you to be more confident and really embrace kind of yourself more fully.
Yeah, I think a lot of these second opinions for revisions, a lot of those patients don't know that it could be better, or we're told that there's nothing else that could be done. And so to me, I welcome most of those visits and try to just approach it with an open mind and set real expectations. But oftentimes those can be some of our happiest patients because there's something that's bothered them for so long, and we end up, doing a minor fix or a major fix depending on the situation, and it makes it a lot better.
Yeah, I do have to. You mentioned the mommy blogs and kind of the plastic surgery kind of community forums that are out there earlier, and I do often warn patients, as much as there can be some good information out there, I also feel that there's a lot of patients who had not so great experiences and they're searching for answers. And ideally, maybe they traveled somewhere else. Maybe they, I don't know don't really know what these situations are. But ideally, you're coming to your surgeon with questions and not kind of searching for answers from an online community. So I don't want, if they really want to, they can obviously, but I don't want them getting too nervous about terrible experiences they see on there, because those are extremely uncommon. And we're here to help them through the process if those do come up, and revise it if we need to. I mean, I want them to be happy and have a great outcome. So it's really important to get them to that finish line.
Yeah, I welcome the patients that ask the questions as soon as they start saying, I saw this online or found this online. Basically say there's a lot of stuff online. There's a lot of good. There's a lot not so good, and so it's just trying to be as informed. But there's one patient who said that they needed a wheelchair or something after a tummy tuck, and it's on there, then it becomes like, I feel like there's a lot of debunking that, where that's just one person's story and it's not even my patient, it's just somebody in the state of Indiana or something like that. And so there's a lot out there, there's some helpful sites, and I try to direct patients to certain communities where they can provide information and share information. And then I try to be that beacon of advocacy and education for them. And this podcast is just another way that we can do that, to give them the resources so that they're hearing it from us, and hopefully preparing them for our consultations with us.
Yeah. On that note, I think this is the wrap up of the first season. Gone over time again. We're really good at that. But I think we might throw together a spontaneous in-person podcast at the Michigan plastic surgery meeting. in the Mackinac Island.
The Academy of Plastic Surgeons, the MAPS meeting in Mackinac Island in about a month now. We're bringing our families. I've never been to the island. There's no cars allowed. Is
there internet?
I was just thinking that, like, do I have to bring my mic and stuff? Like, we have to figure out like what equipment we might need.
They have like horse-drawn trolleys, like wagons.
Yeah, maybe we'll do one on the back of that.
Yeah.
But yeah, it's been a fun ride. We welcome everyone to send in their comments and other topics. We're going to do a lot of work on the side so that we can prepare and bring back more content, more guests, surprise hot topics and great things on the Fuller Butz podcast.
Yeah, thanks for tuning in for the last however many weeks, and look forward to seeing you on the flip side, season 2.
Yeah, see you in northern Michigan, buddy.
Yeah, later.
Thanks so much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @SFullerSurgeryMD or @DanielButzMD. That's Butz with a Z, for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.